Hello and welcome to our high-yield review of endocrine emergencies. Today, we're tackling two of the most critical conditions you'll see in the ICU, diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic state, or HHS. We're going to break down exactly how to tell them apart, what the treatment priorities are, and provide specific tips to help you ace questions on both the NCLEX and the CCRN exams. Let's get started. At their core, DKA and HHS start from the same place, a lack of effective insulin that leads to sky-high blood sugar. This hyperglycemia causes the exact same initial problems for both conditions: profound dehydration as glucose pulls massive amounts of water out through the kidneys, and severe electrolyte imbalances. The key difference, and the most important concept we will cover today, is what happens next. It all hinges on whether the body has any insulin at all. Think of this as a fork in the road. In DKA, there is an absolute lack of insulin. The body has none. Because cells can't use glucose for fuel, the body panics and starts burning fat for energy. This process creates byproducts called ketones, which are acids. This is why we call it ketoacidosis. In HHS, there is a relative lack of insulin. This is key. There is just enough insulin floating around to prevent the body from burning fat, so you get no significant ketones and therefore no acidosis. However, without enough insulin to control the sugar, the glucose level climbs to extreme levels, causing devastating dehydration. So who is our typical DKA patient? Usually, it's a younger person with type 1 diabetes. The onset is fast, often developing in less than 24 hours. The hallmarks are all related to the AA for acidosis. You will see Kussmaul respirations. That's deep, rapid breathing as the lungs try to blow off acid. You may smell a fruity, acetone-like odor on their breath. And severe abdominal pain and vomiting are very common. Their glucose will be high, but usually less than 600. The HHS patient profile is very different. This is typically an older adult with type 2 diabetes, and the condition is often triggered by an underlying illness like a UTI or pneumonia. The onset is slow and insidious, developing over days or even weeks. The hallmarks here are related to the HH for hyperosmolarity. These patients have profound dehydration and, most classically, severe neurological symptoms. Think confusion, lethargy, or even a coma. You will not see Kussmaul breathing because there is no acidosis. Their glucose is extremely high, almost always over 600. This table summarizes everything. For DKA, think younger, type 1, fast onset, and glucose in the 300-600 range. The key labs are the presence of ketones, a low PHH, a low bicarb, and a high anion gap. For HHS, think older, type 2, slow onset, with glucose over 600. The key labs here are the absence of ketones, a normal pH, normal bicarb, and a very high serum osmolality. The main problem in DKA is the acidosis. The main problem in HHS is the dehydration. Now let's talk about treatment, and this is critical. The first priority for both DKA and HHS is not insulin. It is aggressive fluid resuscitation. You must fix the dehydration first. Giving fluids restores blood pressure and organ perfusion, and it even helps lower the blood sugar through simple dilution. We always start with an isotonic fluid, like 0.9% normal saline, often giving 1 to 2 liters in the first hour. Starting insulin without fluids is dangerous and can lead to cardiovascular collapse. Once fluids are on board, we can prepare to start an insulin drip. But there is one critical safety step you must take first. You must check the potassium level. Insulin works by pushing potassium from the blood into the cells. If your patient's potassium is already low, starting an insulin drip can cause life-threatening cardiac arrhythmias. If the potassium is less than 3.3, you must replace it before starting insulin. The goal is then to lower the glucose slowly and steadily. Okay, let's focus on the NCLEX. The NCLEX wants to know that you are a safe, fundamental nurse. For these topics, they will test you on priorities and safety. Remember, fluids are always the first action. For insulin, Know that regular insulin is the only kind given IV, and the biggest risk is hypokalemia. They also love to test patient teaching, so review the sick day rules. And finally, for testing purposes, make the classic association. DKA is for type 1, and HHS is for type 2. Now for the CCRN. The CCRN expects you to think at a much deeper critical care level. For DKA, you must know that your true goal is to close the anion gap, not just to lower the glucose. For HHS, you must understand the risk of cerebral edema from correcting the osmolality too quickly. You also need to be familiar with calculating a corrected sodium to guide your fluid choices, including when to switch from normal saline to a hypotonic fluid. Let's dive into that CCRN concept. The anion gap is high in DKA because of all the unmeasured ketones. The insulin drip stops the production of these ketones. As the body clears them, the gap closes and returns to a normal value of 12 or less. This is your true endpoint for treatment. You can have a patient whose glucose is 180, but if their anion gap is still 20, the DKA is not resolved and the insulin drip must continue. For HHS, the specific goal is to safely rehydrate the brain. The extreme hyperosmolarity has pulled water out of the brain cells, causing them to shrink. This is why you see severe neurological symptoms. Your most important monitoring tool is the patient's mental status. As you slowly rehydrate them, their neurostatus should improve. If it suddenly worsens, you must be concerned about cerebral edema from correcting them too quickly. Let's summarize. DKA is a problem of acidosis, typically in type 1 diabetics, presenting with Kussmaul breathing and abdominal pain. The goal is to close the anion gap. HHS is a problem of dehydration, typically in type 2 diabetics, presenting with neurological symptoms. The goal is to safely rehydrate. For both, the universal treatment steps are fluids first, then check potassium, then start the insulin drip. By focusing on that initial fork in the road, the absolute versus relative lack of insulin, you can understand and predict all the signs, symptoms, and treatment priorities for these complex conditions. Thank you for joining this review. You are prepared. Good luck on your exam.